He finished his MPH from Beirut University. He is interested in NCD research and work. He is currently working as NCD professional officer at the WHO Palestine office. He is helping the Ministry of Health in implementing the PIN in clinics. And the presentation today is part of the assessment of the PIN in 1 district in the West Bank. Nadim Barghothi, please start.
Okay. Good morning, everybody. First of all, I would like to thank AUB, Beirut University, and RESCAP-MED to allow me to present you here this presentation, and of course to allow me to be in Beirut for the first time. I hope it will be not the last. Second, I think it will be I will call my mission here, mission impossible, because I will be presenting such boring things after very interesting Rita's presentation. So of course, I'm going to talk to you here about 1 district in West Bank. This district is small. Inhabitants of this district are 70,000 population, but it's the most affected district by settlements called Salfit, because it has the biggest industrial area, Israeli industrial area inside West Bank, and it has the biggest settlement called Ariel, and so it's affected by occupation. So now I'm going to talk about coverage of care for non-communicable disease in a health district which is called Salfit. What expect to see in this presentation? Something about the things listed here, NCD services in Palestine, something about it. Of course, what kind of information do we have about NCDs, and what 2 words about the package of essential NCDs intervention called PIN by WHO and accepted by Ministry of Health, and after, of course, some recommendations from our data. Of course, I would like to start with this. With the recommendation of your symposium last year, which was improve availability and the quality of data through conducting surveys and establishing registries. This was one of your symposium recommendations last year. So all our work here will depends on 1 very simple register for NCDs in Salfit area. What services do we have in Palestine for NCDs? Of course, many of you know that we have too many health providers. We have the biggest one, the major Ministry of Health, and second one is UNRWA. We have in West Bank 30% of our population are refugees. NGOs, we have big sector of NGOs, military services, and of course the private sector. What we had for NCDs, we had a vertical programs mainly targeting diabetes, and some places may be targeting diabetes and hypertension. Of course, when you have many health providers, you may find duplicated services, and of course, people are shopping by use multiple providers. You may find 1 patient had too many kind of medications from UNRWA, from Ministry of Health, from NGOs, and finally he can visit the private sector. So what kind of information we have in Palestine? Of course, I can't list everything here, but we have the MOH monthly statistical reports. They are reporting every month, but they are counting patient visits, not number of patients attending the clinics. They don't know about them. And of course, they have a MOH annual report. It's a very big book. If you look at it at NCDs, you may find that how many diabetes patients make visits to the clinics, and you will never find how many diabetes patients we have in the clinics in the Ministry of Health. Of course, about the NCD prevalence, we have the stepwise survey 2010-2011, which conducted by WHO and the Ministry of Health. We have some information about the prevalence of some NCDs and related risk factors. And of course, we have the pioneers, academic institution surveys since 90s, maybe 80s sometimes. But we have Beirut University, Al-Quds University maybe, but Beirut University still we have 1 or 2 surveys that we still mentioned in every paper you can read in the literature. What is... Oh, sorry. Okay, I forget. So, what is the package of essential NCDs intervention? The PEN, of course, it's targeting people as a whole, not diabetes only, not hypertension only, not hyperlipidemia only. We're targeting people as a whole, integrating these services into the primary care, and this will be the job of the GPs and the nurses, the teams work in the primary health care clinics. This wasn't the case before because in our case in Palestine, every diabetes patient and every hypertensive patient or NCD patient should be referred to a specialist every 6 months. And you imagine the load on the specialized services, what the load will be. So now it's integrated, and this is the job of the general practitioners in the clinics. So it's a set of evidence-based, cost-effective interventions for detection, prevention, treatment, and care for NCDs and their related risk factors. And you can find it to read further about the PEN, this package in the web, in the WHO website. You can find it everywhere. Of course, MOH started implementing this package in 2013 in Salfit area. Now, by the end of this year, we find MOH implementing it in 6 districts. We'll be implementing it in 6 districts covering almost 1 million population, almost half of that. By the end of the next year, we will have information more and more, of course. This, I'm presenting here results of registry, what registered in 1 year from January to December 2013 from Salfit area. Here, just I want to say something about blood pressure. Of course, all of us concentrating on diabetes mellitus, but looking at blood pressure, out of stepwise survey, we found, or the Ministry of Health and WHO found, and this is, I think it's in the whole region, the same case, that 40%, almost 40% of population above 25 years have raised blood pressure or currently on medications for raised blood pressure. But the raised blood pressure who are not currently on medications for raised blood pressure are 30%. So we don't know if these people are undiagnosed or unregistered or they know about themselves or don't know. So, but we know that they are not taking medications for blood pressure. And here, the routine data, the registers. Of course, in many places, in many clinics, in many Ministry of Health in Arab world, as I know, you may find people are collecting too many data on paper-based, but they are not utilized. They are underutilized. Here, our presentation shows that even simple routine data can be used to illustrate services, gaps, and direct future such interventions. So in Salfit area, after we showed the director of Salfit area such data, he immediately starts the screening, opportunistic screening for people above 25 years or about 40 years. What kind of routine data we are talking here? NCD registered, I will show you now. Monthly aggregated data from paper-based. And of course, every district now has a database, very simple one, Excel. We aim to have a central database for aggregated data from the whole district, so we'll have information about the whole West Bank. And we hope also to have data from Gaza, because we started it also in Gaza. Here is the register as you see the upper part of the picture. It has very simple information: name, ID number, year of birth, and gender, and what diagnosis the patient got, hypertension or diabetes mellitus, and related complications for diabetes mellitus. And the lower part is how the database looks like. Of course, what we did here, we know the expected numbers of hypertension and diabetes mellitus for Salfit district by taking the information from the census, population projections, 2007 census in Palestine, and we assume that the same proportion of people under 25 still the same in the 2013. And of course we used the stepwise survey for prevalence of diabetes and hypertension, and after that we got the information about people from the register. What we found? We found that 64% of all registered patients in Salfit district had hypertension. So they are more than we expected. But the thing that we need to show here is we covering in Salfit area about 22% of the expected patients with hypertension in the district. So although we are targeting everybody for Ministry of Health in the Salfit area, because here I can talk the biggest MOH, because the UNRWA there we have no clinics and the refugee population is minimal in this district. Of course, it's different between clinic to clinic. Some clinics covering 12% of expected number of patients with hypertension, and the others covering 27%. And this is the variation between clinics. This is maybe in the local district Salfit, they should look at it and think about it. Why is the differences? Because we are all living in they are all living in the same socio-economic status, socio-economic situation. So why is the difference? So we need to know, are there underdiagnosis or overdiagnosis in any places? And you will find, we can find that the same for diabetes mellitus. 51% of all registered got diabetes, but here we are covering more. So the Salfit district are covering 58% of the expected number of people of diabetes mellitus. And we can see the variance between the clinics also from 33 to almost 72. But if we, okay, I will finish in 5 minutes. Someone may say that Ministry of Health covering 70% of population because the insured population are 70%. Yes, we recalculate the coverage according to the 70% of the population, but we find still low. We are covering 31% of expected hypertension patient, even with taking into consideration the 70% of population that insured. But in the diabetes, we found that in some clinics, we are covering 117% of the expected. So we are covering more than needed. Why is that? Of course, we find that people using Ministry of Health for diabetes, because maybe here, more than 20 years, not only Ministry of Health, UNRWA, NGOs are targeting diabetes patients for more than 20 years. And I can't say that we are neglecting hypertensive patients, but the hypertensive patients are not targeted as diabetes actively. And of course, the cost of the diabetes mellitus medications may force the patients to use public systems because it's costly, especially when you are talking about insulin, whereas 30% of our diabetes patients are taking insulins. But we don't know if the lower coverage of hypertension is because of under diagnosis or something else. We need to look at it more. So what we see here, we need to maybe active screening for early detection of NCDs, especially hypertension. Especially hypertension. We need an active program to discover where are the 80% of people with hypertension treated. And of course, we need more resources for the primary care to deal with the expected number of patients in the future. And of course, we need to promote regular review for the routine clinic data. And here I would like to ask, we are talking about the universal coverage of health in the last 2 years. Okay, in the last years, we're talking about the universal coverage of health. Are our systems in Arab world ready to have 80% more hypertensive patients or not? We need to think about it. And finally, I would like to thank everybody in Salfit district because they did a great job. They did something that they didn't used to do before. So they used to refer all these patients, but now they are treating them, taking responsibility of these patients. Thank you.
Thank you, Nadim. I would like to open the floor for questions, but I would like to also add one comment, if I'm allowed to. Just to say, this type of research is new for people in my country. We are used to classical research. If we want to study NCDs, we will ask for money to go and conduct a survey. This is a new concept of using routine data and a good way of survival, because this is not an expensive research, but at the same time, it is a very informative type of research. Now, it's in its early stages, and it's taken by initiative from Nadim and the team from that clinic. I think the WHO also are encouraging this type of research in the region, so hopefully it will be more, we can conduct more research based on routine data rather than expensive research. So I would open the floor for people for questions. Okay, we have here and Salim. Okay. So we'll take 2 questions and then Nadim respond. We'll take another question.
Shall I start? Okay. Well, thank you, Nadim, for bringing up the topic. Dr. Barghothi, good morning. I'd like to initiate with you a global thinking about the values of continuing our STEPS surveys in this part of the world. When you get figures that say 50% of a population in one district has diabetes, when you get figures that all hypertension, whether diagnosed or not, is about 60%, the first reflex of an epidemiologist is to say, where is the artifact? Is this really a valid information?
Sorry, I need to say something here. I didn't say that we have prevalence of diabetes 51%. I said that among people with NCDs registered in Salfit districts, among people registered, we have 51%, because we have 12.
So this is not a population survey?
No, it's not. It's not a population survey. And
it's a description of your patients?
No, it's not. We have 12% of above 25.
Let's take one step before and talk about steps. I'm too bad that our NCD regional director is gone. It's my impression from our experience with steps in Lebanon and some other places in the Arab world that a large part of the data that is fed into the survey is invalid and invented, because the surveyors are not followed up well in the field. They cannot go to lots of different difficult places, and they end up fudging data and putting it into the system. So if this is really our feeling, and if this feeling is shared all over the place, we need to, at some point, stand up and say to WHO, stop selling us steps and help us set up the surveillance system that is based on ongoing validated data coming from our primary healthcare centers that we can actually build on. What is your impression about this? You share my feelings about the validity.
Well, no. Let's take the second question and then we'll have a combined reflection.
Okay.
multi-provision of NCD services by different sectors that we are really suffering from, and my understanding this brings more harm than benefit to patients. This also not apply in Palestine, it applies in Jordan and in many countries. Has been taken any steps in order to standardize this issue? Is there any steps to have one unified NCD file in West Bank for patients? This, I think, could be done through the e-health system, through medical records. Is there any steps or is there any plan to standardize such a file for one patient that he can get a service only from one healthcare provider?
So, Doctor, here about steps, I'm not here saying anything about steps because I just took one number of it, the prevalence. And I may agree with you or disagree with you about the steps and the data taken from the clinics. I don't know about the coverage in Lebanon. I know about Palestine. I can't rely on the clinics data saying the prevalence of any disease. We can't rely. So as stepwise, as population-based, will be more informative. Maybe it needs some enhancement, maybe some help for ministries of health to do it. But we can't rely on the data from clinics to say anything about the prevalence. I don't know about other countries. If they have universal coverage for people, they can. But if you haven't a universal coverage for people, you can't. I don't know if you agree with me. And here, again, about the prevalence, I didn't talk about anything about prevalence here, but I took the number of prevalence to have, to estimate how many patients with hypertension, how many patients with diabetes we have in this district, and village by village. This is what I use. And the prevalence of hypertension and diabetes is not different from the other surveys coming from the universities, from the academia, taken from the stepwise and from academia, especially diabetes. We have the same rates of prevalence of diabetes. Not 50, I'm not talking that we have 50%. Doctor, you didn't get my point. I took, not specialized clinic. If we have clinic in Salfit area, let's say Azzawiya. Let's say Azzawiya. You have a nurse here from Azzawiya, she working there. We have 200 files with NCDs. So we have 100 files of these patients have diabetes. But in Azzawiya, we have 12%. We assume that, like the population, we have 12% above 12% got diabetes above 25 years. I will never say that we have 50%. If it's not clear, I can clarify more. I never said that. Okay. Dr. Yusuf, of course we are working, but you know, we'll never be able to resolve this problem without resolving the political problem, because neither the UNRWA nor the MOH can say to a patient, don't come to our clinics. So we will never be able to have one file, because it's a political problem. And I think you know about that. But now they are working together in women's health. They're trying to unify something. Yes. Thank you.
Okay, thank you, Nadim. I can see another finger, but we're short of time. So thank you, Nadim, and hopefully we can continue the discussion during coffee break. Thank you.